Hi everyone. This week we're going to learn about the management of head and neck cancer. When it comes to facts and figures on head and neck cancers, they are divided into two sections: oral cavity and pharynx, and then the larynx. Oral cavity and pharynx cancer make up 3% of all newly diagnosed cancers in the United States. Risk factors include tobacco use, heavy alcohol use, and the HPV infection. Average age at diagnosis is 63 years old. The 5-year relative survival rate is 65% when you combine all stages together. Larynx or laryngeal cancer makes up less than 1% of all newly diagnosed cancers in the United States. And smoking is the major risk factor for this cancer. The average age at diagnosis is 65 years old, and the 5-year relative survival rate for all stages combined is 61%. Within the presentation, I have included illustrations of the different sites of head and neck cancers from different views. Since head and neck cancers are more rare, we will not be abstracting these types of cases in classes next year. But make sure you save these illustrations or use others that demonstrate the head and neck anatomy, such as your A&P textbook. Knowing the anatomy and being able to visualize it is very important when abstracting these cases. Experienced abstractors will tell you that these cases are the most difficult to abstract. Here's an illustration of the tonsils from the anterior view. Did you know that you had a pharyngeal tonsil and a lingual tonsil, as well as your palatine tonsils? With so many subsites of the head and neck, you can see why these cases can be the most difficult to abstract. Here you can see the multiple tonsils from the side view. The larynx is divided into subsites consisting of the epiglottis, supraglottis, glottis or vocal cords, and subglottic. A primary head and neck cancer can originate in any of these subsites. The pharynx consists of the nasopharynx, oropharynx, and laryngopharynx, also called the hypopharynx. This is an illustration of the paranasal sinuses, these are also included in the head and neck cancers. Here's an illustration of the head and neck regional lymph nodes. And this is a lot of different lymph nodes in just a small area of the body. So it can be very difficult when understanding the different levels of lymph nodes that are involved by these cancers. There are 5 main types of head and neck cancers: laryngeal and hypopharyngeal, nasal cavity and paranasal sinus, nasopharyngeal, oral and oropharyngeal, and finally the salivary glands. When it comes to screening for these cancers, people who routinely drink alcohol, currently smoke, or are past users of tobacco products should receive a general health screening examination at least once a year. This is a simple, quick process in which the doctor looks in the nose, mouth, and throat for abnormalities and feels for lumps in the neck. And the dentist many times will do an oral screening. They'll feel, all the different parts of your mouth to make sure there aren't any lumps or bumps. Listed on this slide are just some of the many signs and symptoms that a person may have when diagnosed with head and neck cancer. I recently heard a commercial on the radio talking about signs and symptoms of head and neck cancers. Even though head and neck cancer is not a common cancer site, it is great that people are getting educated on it. Hopefully this will make people more aware and seek medical attention right away and be diagnosed at an earlier stage. Because as we know, the earlier you're diagnosed with these cancers, the better your outcome is. Procedures that could be performed to diagnose a head and neck cancer could be physical exam, endoscopy, laryngoscopy, biopsy, CT scan, PET scan, and possibly an MRI to determine if the primary site is operable or not. Most head and neck cancers are squamous cell carcinomas. Performing special tests to see if the cancer is HPV or EGFR positive will determine which treatments are likely to be the most effective for these patients. Salivary gland cancers have different histologies and are classified as adenocarcinoma, adenoid cystic carcinoma, and leukoepidermoid carcinoma. The pathology slide on the left is a tongue cancer that is squamous cell, but of the papillary variant. Even though most head and neck cancers are squamous cell carcinomas, there are many, many variations of squamous cell carcinomas. The pathology slide on the right is a mucoepidermoid carcinoma of the salivary gland. So you can see they are very different looking. Head and neck is one of those cancers that must be treated with a multidisciplinary team. Not only the usual oncologists and surgeons, but a plastic surgeon to reconstruct any defects caused by the surgery, as well as a dentist to remove teeth, especially for the oral cavity primaries. A nutritionist for these patients that have to have a feeding tube. And even if they don't have a feeding tube, a nutritionist will make sure that they are getting the nutrients that they need to get through their treatment. And if needed, then they would have to, have a feeding tube placed. These patients, whether chemotherapy, radiation therapy, they have difficulty eating during the treatment, and most have to have liquid diet, which is sometimes by way of the feeding tube. That's the only way they are able to get the nutrients that they need. A physical therapist and a speech therapist are also an important part of the team as well for these types of cancers. Many cancers of the head and neck can be cured, especially if they are found early. Although eliminating the cancer is the primary goal of treatment, preserving the function of the nearby nerves, organs, and tissues is also very important with these types of cancers. When planning treatment, physicians must consider how treatment might affect a person's quality of life, such as how a person feels, looks, talks, eats, and breathes. These all matter to the patient, and they must be taken into consideration, and their wishes must be taken into consideration when planning the treatment. Overall, the main treatment options are surgery, which we'll discuss in more detail in a moment. Radiation, usually IMRT, since it has a smaller target. And then there's chemotherapy and targeted therapy. Surgery or radiation therapy by themselves or a combination of the listed treatments may be part of a patient's treatment plan. Sometimes they only have to have surgery. Sometimes they only have to have radiation. Just depends on the primary site and the stage of that cancer. Types of surgeries include laser technology such as CO2, Excision of the tumor may include procedures such as stripping the tumor off of the larynx or pharynx, glossectomy, either partial or hemi, half of the tongue is removed, tonsillectomy, laryngectomy, and pharyngeal-laryngectomy. And I forgot the parotidectomy. A lymph node dissection is usually performed if the primary organ is dissected, and bilateral lymph node dissection may be performed. Sometimes, depending once again on the site, sometimes only one side, the unilateral neck dissection will be done, but sometimes they'll do a bilateral lymph node dissection where they remove the lymph nodes from both sides of the neck. There are only a few site-specific data items collected for most of the head and neck subsites, and they pertain to the size of the lymph nodes and the extent of the lymph node involvement with the cancer. The oropharyngeal cancer, the HPV-16 status is collected. HPV-16 positive and HPV-16 negative cancers are staged differently. So that is a very important test that should be done on all oropharyngeal tumors. Let's quickly look at the head and neck NCCN guidelines. In a way, these are kind of easier than some of the other sites that we have looked at in the past. So here we have head and neck cancers. So we click on that, and then as you can see, all of these sites are included in the head and neck guidelines. Click on that. And then go to, so as you can see, for the most part, the table of contents is by the cancer site, the subsite of the head and neck cancer. And then if it's very advanced, then you can just go to that. And then once again, you have recurrence. You know, if a patient recurs, the physician can go directly to that section and determine what type of treatment should be done. There's also what they call an occult primary, and that's when the patient is proved to have a head and neck cancer because of positive neck lymph nodes, but they can't find the primary cancer. There's no primary tumor anywhere else. So that's when there's an occult primary. The patient has metastatic disease to the lymph nodes, but they don't know where the original tumor started. And then we have the salivary and even mucosal melanoma is under this section. And then once again, we have principles of the different things or of the treatment. So as you can see, if you go to the oral pharynx section, two different set of guidelines. If it's HPV negative, you click on that. If it's HPV positive, you click on a different one. So it's very important that you click on the correct one and then go through, you know, the different sections. Now, if you already know whether it's HPV, you know, positive or negative. But let's just say we know a patient has, or the physician knows the patient has oral pharynx cancer. We would click on that. Once again, here's the workup. So this is the workup that the patient could have. And then we go biopsy. Is it P16 negative or is it P16 positive? Okay, and then we go by, you know, clinical staging. What is the staging? And then that's where we have to click on the specific one for that stage. And then we'll go through, you know, the treatment options. And as you can see here, a T4B, N0 to N3, that's when you see the treatment of very advanced head and neck cancer, all right? Or if the patient has unresectable or is unfit for surgery, you would also see that section. Or if the patient had distant metastatic disease, that's considered very advanced. Okay, so then once you know the clinical stage, you would click on it, and then it's going to give you your treatment options. And as you can see, for all these different stages, it breaks out into no adverse features and adverse features. And you'll see that at the bottom of the page, there's a footnote that describes what an adverse feature is. Okay, so that's how you know which one it would be. So as you can see with the head and neck, many of the treatments, if you look at it early stage, sometimes can just be surgery, sometimes only needs radiation, where others, surgery and chemoradiation or chemoradiation prior to surgery. So it all has to do with not only the type of treatment, but the order in which those treatment modalities happen. So take some time to kind of learn a little bit more about head and neck NCCN guidelines. If you have any questions, please let me know. This week you have a quiz that covers weeks 12 through 14, which includes the hematopoietic neoplasms, esophageal, stomach, as well as head and neck cancers. Only 2 more weeks of the semester after this week. You guys are doing a great job. Hang in there. It's almost the end of the semester. Have a great week, everyone. Take care.